So with that, I'm going to turn over the microphone to Maureen. Do you want the handheld or? Yeah. Okay. Great.
I may decide to put this down. I'm not super comfortable trying to advance slides, hold the microphone, and a couple of notes. So we'll deal. So again, just welcome to the course. I have maybe about 15, 20 minutes to go through just some basic didactics about strategies to deal with difficult conversations. Originally, when this course was started, it was talking about delivering bad news. But what's bad to one person may not necessarily be bad to someone else. So talking about serious news, I think, is something that's really important, and realizing that people have different values, different perceptions, and just trying to be on our patients' and families' level is something that's really important when we have these conversations. So for the objectives for the next 20 minutes or so are to identify the challenges of talking about goals of care, to describe talking maps available to deliver serious news, attend to emotion, and elicit goals of care, to apply these maps to our clinical practice scenarios, and then to improve our confidence in being able to communicate during medical crises with patients and their families. So, what are some examples of bad, serious news that you've had to deal with in your careers so far? We're going to do this interactive. Jack.
Pediatric traumatic injury or arrest, new cancer diagnoses.
Mm-hmm. Great. I mean, for me, honestly, the pediatric ones are the absolute worst. It's always very difficult to give a family news that their child has died, perhaps that they have a life-limiting illness. Really, really hard. Even to talk to a family about a child being developmentally delayed is really, really hard. You mentioned the cancer diagnoses, also very difficult. People come in with a little bit of belly pain, and suddenly they're faced with this diagnosis of, you know, a widely metastatic tumor. Anything else people have dealt with? Right, yeah, medical errors, definitely, definitely. Yep.
We have a new member of our group.
Oh, great.
Oh, and another one. No.
Oh. Okay. I see your name is Ari. You want to just 2 seconds brief intro?
Sure, I'm Maureen, I'm a second year resident in Massachusetts.
Great. And why are you taking this?
Why am I taking
Why are you taking the course?
We have to give bad news all the time, so it's nice to have some help learning how to do that.
Okay, great. Okay. So we're just going through some examples of bad, serious news that we've had to deal with or concerns moving forward. Any other thoughts? For me,
I find that a lot of people, like patients, like, you know, I'm sorry your hip is broken, or like, you know, you actually do have to stay in the hospital. So like those sorts of conversations may not sound like bad news to us, but get perceived that way by patients.
exactly, exactly. Other examples just for me are, you know, dealing with family members who have one set of expectations for their loved ones, but the reality is such that their family member is not going to be leaving the hospital the same way that they came in. So just trying to help manage expectations moving forward. I think, you know, the elderly patient, just as you said, the trip and fall with the hip, what that actually means as far as care plans moving forward, all those are really, you know, difficult, challenging conversations to have. Okay. So what are some of the challenges, actually, of giving serious news in the emergency department? Time. Tell me a little more.
Depending on what's going on in the emergency department, whether you can really focus your attention on what you need to do at that time,
Mm-hmm.
and then whether you have the actually the amount of time you need to devote appropriately to it.
Mm-hmm. Okay. Other thoughts about time? So For me, the other big piece as far as time is not only having the conversation, but actually getting enough background information to be able to give information to the family and patient. People talk about time in the emergency department, having that conversation. I think in a lot of ways we're really blessed in that we can go in, give a little bit of news, walk out, let the family and patient digest that news, then go back in and continue the conversation, as opposed to people who are up on the wards or in clinic when they have 15, 20-minute time slots, they need to get it all in. We can spread that 15, 20 minutes out and allow the patients to process the news that we're giving them. So in some respects, time for us is really a blessing. Other thoughts, I saw lack of relationships. What does that mean to you guys?
Maybe not buy in with the patient or the family to you as their physician yet, or if you're not going to be the
Right.
person taking care of them in the long term.
Right. So part of it is trust. They don't know us. We don't know them. Okay? We don't know who they are, who they were, and who they hope to be. So those are all things that, make it a little bit challenging for us in the emergency department to give serious news to patients.
What else? Did I give you a hint? What else is going on that you need? The world, right? I mean, it's like, it's not a quiet, calm place, and you're multitasking and you're getting pulled in 20 directions at once when it's busy. So the setting itself doesn't lend itself well to some nice, calm, peaceful conversation, right? It's finding a quiet space, finding some privacy, finding someone who can take care of the traumas that are going to come in or whatever. So it's challenging.
I can say for my emergency department, we actually do not have a family room, so all of those conversations, despite what all the literature says, actually does take place at the bedside. It's a very small, crowded emergency department, really difficult to be able to get some kind of privacy, so it's just a challenge, really. Other thoughts about that? Okay, so why do we do it? What are the benefits of having these conversations?
Sometimes we're just forced to have to do it because you're responsible not to tell someone when you find the CAT scan or, right?
Yeah, yeah. So it's really, imagine that one of us were on the other side of the bed. You would want to know it's the right thing to do. It helps you plan for the future. It helps build relationships more with your family members and the physician moving forward. It does begin to build trust, I think, in the medical profession for people who have not had much exposure to medical decision-making and medical crises. I just, for me, I just think we really don't have a choice. So it's something that we need to do, and it's something that we should begin to feel comfortable with, moving forward. And realizing that in the emergency department, we do a variety of procedures, okay? We set up to do central lines. We intubate patients. Whenever we're doing something like this, we have a roadmap in our head about all the things that we need to do in order to prepare to do the procedure successfully. Try to look at these conversations as a procedure, and hopefully we'll give you some roadmaps, checklists to go through before you're actually having these conversations so that you can succeed in these conversations just like you can succeed in doing an intubation and putting a central line in patients. Okay, so what we're going to be talking about here is a variety of tools to get you through critical conversations when things have changed from the patient's baseline status, when it's important for the patient and family to come to some kind of a decision as far as next steps in care. And one of the tools that we have is a mnemonic remap, and we'll go through that in the next couple of minutes. And basically, patients come into the emergency department, like I said, a little bit of belly pain. They find out they have metastatic, cancer. Come in with a little bit of shortness of breath, find out that they have really bad lung cancer. Come in with a trip and fall. Grandma had been doing really well, was found to have atrial fibrillation, put on an anticoagulant, trips, falls, and has a massive, devastating neurologic injury. What are the next steps? And so the mnemonic that we use is REMAP, okay? And what the REMAP actually stands for is reframe, basically saying, okay, we're in a different place now. What's important to us? How are we going to be able to go forward? Expect emotion is E, okay? Realizing that whenever someone hears really bad news, the reaction to the stress is emotion. Map the future, understanding that people have different values and different goals, so trying to understand what those goals and values are will help you align with the patients and their families to move forward, and that's the A in REMAP. And then the P is plan for the future, plan for next steps, and how to support patients and families. So reframe, okay? Patient comes in, they have bad CAT scan. So given this news now, it seems like it might be a time to talk about what to do, okay? Basically, you're shifting from what had been a care plan previously to perhaps a new set of goals and treatment plans. The way to introduce this might be to say we're in a different place. Things have changed. We have more information. We're at a point now where treatments are unlikely to help and may make either you or your loved one worse. And the way we do this is using another mnemonic that I don't know whether or not you are familiar with, but it's really the spikes mnemonic. And this is really, I think, one of the bases of giving serious news. It's not only for patients who have devastating illnesses, but this is something when you're talking about a medical era, this is really a great mnemonic to fall back on. And basically what it is the S is setting, looking for a quiet place, but also not only looking at the environment, but trying to set yourself up to have a successful conversation. And that would be reviewing your mnemonics. Mindfulness training is really helpful before you actually walk into one of these situations. Know what's going to calm you down. Some people will actually say the way you sit at the, with the conversation will really help ground you. And I have actually found that sitting down on a chair with my hands on my legs really helps steady me. I don't sit with my legs crossed, which is the way I do all the other times, but it enables me to have a better rapport with the family moving forward. And the other thing is crafting a headline. Knowing how you're going to want to break this difficult news before you actually walk into the room is something that's really important. And we'll go through that as well. The other piece of P is patient perception. Ask the patient what they know. What do they think is going on? What have they been told? How do they anticipate next steps? One of the big communication tools from Vital Talks is something called ask, tell, ask. So you ask, you give information, you ask the patient's perception of what you've told them, and then you're able to move forward. So the I is the invitation, asking the patient and their family, is it okay for us to talk about this now? Is there anyone else perhaps that you might want to be at this conversation, and then you can move forward. The K is giving the knowledge. You want to do it in short bites. You want to give a warning shot. I'm sorry, I have the result. I resulted the test, and we're going to be, and it doesn't show what we had hoped, and then give more information and move forward with that. The E is emotion, and that's something we're going to spend a lot of time in this particular session. How we're going to be able to deal with people's emotions, and give you tools to acknowledge the emotions and move conversations forward. And the S is a summary, again, strategizing with the patients, what's important for them moving forward, showing support, and again, asking them if they have any questions questions? Do they understand? And going forward. So that was the R piece. And I know it's kind of confusing to have all of these mnemonics thrown at you at once, but I do think that spikes is really the basis of the R for reframing, and that without understanding that, it's really difficult to shift the conversations. Okay, so E, expect emotion. One of the most important parts about that is you're going to give someone bad news, be quiet, okay? Allow them to feel their emotions. Because without that, you're not going to be able to get to the cognitive pieces for patients to be able to process next steps. And this is basically just a reiteration of what Eric had said. It's a normal response to stress. It's involuntary, unstoppable. Even if people are actually asking for more details, they're not necessarily there with you. So allow them that space. Say to them, this must be difficult for you. And wait and see where they go next. By attending to the emotions, it enables you to align with the patients as well, realizing that they know that you're with them in this next step of their journey. And don't try to fix. Don't say it's going to be okay. It may not be okay. So just be forthright with them and truthful. So the nurse mnemonic. We're going to be practicing this in the sessions. And basically, N is name, U is understand, R is respect, S support, and E is explore. So how do we actually do this during our conversations? So you just gave someone bad news, CAT scan, shows metastatic disease. You can say to the patient, I can see how disturbing this is for you. Or you could say, this must be very challenging for you. Just acknowledging what you see in front of you. And then giving time for them to tell you a little bit about what's going on, and moving forward in the conversation. Understand. Show that you're supporting them. I can't imagine what this might be like. Okay? Just some strategies. R, respect. Your dad is so lucky to have you here to help. Or, I know that you've really tried to, continue the treatments going forward. It must have been very difficult for you. I understand you have a lot of family obligations. How to move forward with that. Support. We'll try to help you and your family moving forward. We'll have people to come talk with you. We have social work available for you. E, explore. Tell me more about that. And that, again, is one of the other bases of Vital Talk. So ask, tell me more. Okay. This part of the conversation, the M, I think is the most challenging part of the conversations. Map out the future. What does the future look like for you? What's important to you going forward? You've just had this serious news brought to you. What are your goals? How do you see the future looking for you? And we'll be able to practice this more in the sessions going forward. A is aligning with the family. As I listen, a few things stand out, showing that you heard what the patient's and family's goals are moving forward. It seems to me that you're saying that, whatever it is that they're saying, it's really important for me to go home, to be with my family. It's really important for me to have as much treatment as possible. And different people's goals are going to be different. It's important for us to meet our patients where they're coming from, not giving our goals and putting them on the patient if we were in that situation. And plan, again, treatments to uphold the values. Here are some things that we can do to match your values based on what you said. Here are some things that we should not do. So basic skills, I think that underpin all of the Vital Talks mnemonics are ask, tell, ask. Whenever you're in a situation and you really don't know where the patient is coming from, tell me more. Ask where they're coming from. And you'll get something to be able to, you'll usually get something to be able to continue the conversation moving forward. And then the I wish statement. When you're giving really devastating news to a patient, there is no more treatment. I wish things were different. Okay? And again, practice, practice, practice. We all start slow, build up speed, and for some, they're able to do these really wonderful things. And I hope that all of you will be able to have conversations easily with grace and humility.